we're on to antiemetics. We're still in chapter 16. Antiemetics mean to prevent nausea or vomiting, as well as vertigo and motion sickness. Our first option is anticholinergics. For the treatment of motion sickness, usually they use scopolamine, which is a patch that goes right behind the ear, or dimenhydrinate, which is Dramamine. Meclizine is also used. It's an antihistamine used for preventing nausea, vomiting, vertigo, and motion sickness. These medications can all cause drowsiness, which is the most common side effect. Meclizine is a little better. It's not as powerful as scopolamine and dimenhydrinate, so you're not going to get that overwhelming drowsiness, which is why some people prefer it over other antiemetics. Antidopaminergics is an antiemetic that interferes with the stimulation of chemoreceptors in the CTZ, which is the chemoreceptor trigger zone. Basically, if it interferes there, it's blocking messages to the GI tract, so the patient doesn't feel nauseous anymore. Examples of antidopaminergics are prochlorperazine, promethazine, and metoclopramide. Serotonin receptor antagonists are our next antiemetic. You guys will get pretty familiar with these in chemo patients. Usually they're used for post-operative nausea and vomiting or chemotherapy-induced nausea and vomiting. And they also work in the chemoreceptor trigger zone, as well as peripherally or not within the brain to help with nauseousness and vomiting. Side effects of all antiemetics include sedation, drowsiness, confusion, anxiety, dry mouth, blurred vision, extrapyramidal reactions, which is a movement disorder where somebody sort of has disjointed movements, so instead of moving fluidly, they are moving with a little jerking motion. You'll see that especially in the children and elderly. You also want to be careful using antiemetics in patients with cardiac arrhythmias. Interactions. Antiemetics can interact with a lot of different medications. Drugs that prolong QT interval. Again, there's our cardiac arrhythmias. CNS depressants, because antiemetics make you drowsy, so do CNS depressants, and we don't want to bring someone's respiratory rate down too low. And concomitant use of metoclopramide, which is itself an antiemetic, but they do interact and can cause serotonin syndrome. SSRI antidepressants, again, we're going to talk about serotonin syndrome here. With promethazine or metoclopramide, we're increasing our risk of serotonin syndrome if we're using them with antiemetics. So I'm going to move into chapter 17. This will be a lot of probably reading off the cuff here because I haven't done a study guide personally on this one. So, chapter 17 is all about anti-infectives. We're covering antibiotics, antifungals, and antivirals. This is a huge chapter. It's got a lot of information. I may not cover everything, but I'm going to try to give you like a basic overview of it. So the chapter talks about resistance. Resistance occurs when organisms overcome the antibiotic, what it is doing to kill the organism. They develop a mechanism to sort of defeat it. Resistance usually happens when patients are misusing an antibiotic, if they're taking it when they don't necessarily need to, if they don't finish the medication, the full course of the medication. So there's a lot of different ways resistance can happen, and it's kind of a scary thing because the more resistant bacteria or fungal infections get, the less medications we have to treat them, and somebody who has high resistance to antibiotics might kind of run out of treatment options and might not be able to get better. So you might be familiar with methicillin-resistant Staph aureus, which means it doesn't respond to that particular medication, or it's also called MRSA. MRSA is pretty hard to treat. It kind of takes over, and it's very difficult to get rid of once a patient has it. It can be pretty scary because patients can die from infections. There's a lot of talk about vancomycin-resistant enterococci as well. Again, scary, can be very difficult to treat, so we try to be careful with our antibiotic use. So, selection of anti-infective drugs is based on several factors. The site of the infection, is it topical, is it in the lungs, is it in the bladder? Hepatic or renal function, a lot of these medications are excreted or metabolized by the liver and the kidneys, so we need to be careful there. Patient age, children don't necessarily take the same antibiotics we do. Sometimes they have fewer choices. Pregnancy or lactation, and the likelihood of the organisms developing resistance. as well as any known allergies. Antibiotics are the most common source of allergies, especially amoxicillin, penicillin, sulfa. So there's a lot of different things we can do, but at the same time we're limited when it comes to somebody who has multiple allergies. Okay, so vaccines or immunizations, we're going to skip over that. I'll let you read that on your own. We're going to move right into aminoglycosides. Aminoglycosides, gentamicin is probably the one you're most familiar with. Tobramycin is another option. And unlike before when we've had names where they end in mycin, it doesn't necessarily mean it's an aminoglycoside, because we have a whole different class that we're going to cover in a little while called macrolides, which also ends in mycin. So just because it sounds similar doesn't mean they're in the same class. You just have to kind of get familiar with what each class is. So aminoglycosides, usually used to treat gram-negative bacterial infections such as E. coli and Pseudomonas, as well as gram-positive such as Staph aureus. They're used in the short-term treatment of many serious infections such as septicemia, which is bacteria in the bloodstream. Again, we talked about gentamicin, amikacin, tobramycin are other examples. They're usually not absorbed too well through the GI tract, so they're almost always administered IV or IM straight into the bloodstream. We'll often draw serum or serum peak or trough levels to make sure that we are hitting our target, especially with these medications because they can have some pretty toxic side effects. We'll go over those side effects. The first one is nephrotoxicity, which is kidney damage. Ototoxicity, patients can have hearing loss. Neuromuscular blockade, and CNS symptoms. So we want to be careful with anybody who already has a history of hearing loss or ringing in the ears. Anybody who has reduced kidney function, is dehydrated, pregnant or nursing women, and infants and older adults. Interactions include other ototoxic drugs. I'm not going to list them out for you. They're right on page 298. General anesthetics or neuromuscular blocking agents, and antiemetics, because antiemetics can mask the symptoms of ototoxicity. So it can be kind of an intimidating class of drugs, but they are used quite frequently. Cephalosporins are beta-lactam antibiotic derivatives, and they are similar to penicillins, related, but they're not exactly the same. Sometimes if a patient has an amoxicillin or penicillin allergy, they might also be allergic to cephalosporins, but it's a small percentage of cross-reactivity. So just because they have an allergy, sometimes we will still test it out on a patient and make sure that we're not excluding an entire class of antibiotics. This is probably the largest class of antibiotics in antibacterial medications. In general, they are broad spectrum, which means they work on a ton of different bugs, and they are active against many gram-positive and gram-negative bacteria. This class is so big it has different generations for medications. First, second, third, fourth, and fifth, fifth being the newest. First generation drugs, for example cephalexin, most of us have probably taken this at some point in our lives, usually used in skin or soft tissue infections as well as urinary tract infections. Second generation example would be cefaclor. And again, these are all going to usually start with CEPH or CEF. So cefaclor is usually effective, again, it's broad spectrum, sometimes used in pneumonia. Third generation example would be ceftriaxone, which is an IV medication, usually effective against more gram-negative bacteria than the others, and is sometimes used for the treatment of sexually transmitted infections. Ceftazidime is also a third generation and is active against Pseudomonas, which is another scary bug that can be difficult to treat. Cefepime is fourth generation, and that's again good against gram-negative and gram-positive, and that is also IV only. Okay, so fifth generation, ceftaroline, used in skin and soft tissue infections and community-acquired bacterial pneumonia. It is the first cephalosporin that is active against resistant gram-positive pathogens, including MRSA and vancomycin-resistant Staph aureus. So we kind of reserve ceftaroline for those patients who are not responding to their antibiotics. It's IV only, and it's expensive, and so we reserve that antibiotic for special cases. Side effects can include hypersensitivity, blood dyscrasias, or increased bleeding time, or transient leukopenia. renal toxicity, nausea, vomiting, and diarrhea, as well as site reactions where the IV or IM administration is happening. We want to be careful in anybody with a known allergy to penicillin, or of course a known allergy to cephalosporin. Prolonged use can lead to what we talked about earlier, which was Clostridium difficile, which is basically we've wiped out all the good bacteria in the gut, and now there's those nasty ones hanging around causing diarrhea. Interactions with cephalosporins, increased effectiveness with probenecid. Probenecid is that medication that prevents reabsorption, or prevents excretion, so the medication stays in the body for longer, as well as it can interact with alcohol. It's called disulfiram-like reaction. So if you're drinking alcohol at the same time you're taking these antibiotics, you can have a reaction that makes you violently ill. So our next class is going to be macrolides. Macrolides include erythromycin, azithromycin, and clarithromycin, and are usually used for respiratory tract infections, skin conditions such as acne, some sexually transmitted infections, or if the patient has an allergy to penicillin. They're considered among the least toxic antibiotics, and therefore a little easier to give. You don't have to monitor. There's not a ton of side effects that go with them. A ton of interactions. So, let's see. Side effects include anorexia, nausea, vomiting, diarrhea, which is pretty common with a lot of medications, and super infections. Precautions: we want to be careful in anyone with liver dysfunction, or GI disease, electrolyte imbalances, and these medications interact with I said earlier they don't have a ton of interactions. What I meant to say was they don't have a ton of side effects. These medications do have some interactions. Erythromycin and clarithromycin are potentially more interactions than azithromycin. So they have interactions with carbamazepine, which is a medication for seizures, as well as cyclosporine, theophylline, benzodiazepines, warfarin, digoxin, and statins. So there's a warning at the bottom of the page there, and these warnings are always pretty big deal. And it says macrolides can cause abnormal, potentially fatal cardiac arrhythmias when combined with the following drugs: calcium channel blockers, verapamil or diltiazem, antiarrhythmic agents, and certain antifungals such as fluconazole, as well as quinolones, which are your fluoxetins. We'll talk about those in a minute. So we always want to be careful when we give those medications that we're not giving them together. And by together, I mean at all together, like not in the same day, not in the same moment in time. So we generally try to avoid those combinations.